And our first speaker is Dr. Peter Neligan. He is professor of surgery at the University of Washington. He is the director of the Center for Reconstructive Surgery, and he established the Lymphedema Center at the University of Washington Medical Center, which is part of the LE&RN Centers of Excellence Network. He has 12 books, 85 book chapters, and over 200 peer-reviewed scientific papers. He has one of the largest experiences in lymphatic surgery in the United States. Dr. Neligan, thank you for joining us.
Hi there. My name is Peter Neligan, and I'm going to share with you my algorithm for treatment of lymphedema. And what I thought I would do is to walk you through where I'm at now, how I got here, how things have changed and will continue to change as we learn more about lymphedema. My disclosures are book royalties from TEMA and Elsevier, and as well I'm on the medical advisory board of Microsure, which is one of the robotic, microsurgical robotic companies. And before we start, I want to talk a little bit about nomenclature. And this is something that was brought up by Babak Morara, essentially to allow insurance companies and others to get a better idea of what these surgeries are about. So you're all familiar with the LVA, VLNT, liposuction. And Babak suggested that we change these names so the anastomosis will become a bypass or an LVB, which gives better information on what the surgery is about, really. Lymph node transfer will become lymph node transplant, vascularized lymph node transplant. Lympha, which doesn't really convey what the surgery is about, becomes immediate lymphatic reconstruction, or ILR. And one that I've used myself is minimally invasive tissue excision, or MITE, for liposuction, because insurance companies equate liposuction with cosmetic surgery, which this is not. So when I first started treating lymphedema, obviously do history and physical on everybody, and the only investigation that we had available was lymphoscintigram. And once I got a diagnosis of lymphedema from the lymphoscintigram, the only surgical option I could offer patients was direct excision. And I'd like to just pause for a minute and show you that there still is a place for direct excision. And I'm going to show you some cases that are more recent than what I started talking about, that I've done in the last few years. And this is an example. This is a morbidly obese 50-year-old man with not significant lymphedema of his lower extremities, you can see here, but he's got this huge localized lymphodematous fold or festoon. And that's not going to go away even if he loses weight, and he can't walk with this thing. And the only thing you can offer him is direct excision. But you have to warn him that excising this is not a straightforward deal. These wounds are slow to heal. And so I put these old-fashioned retention sutures in, tied over a rubber drain, and I leave them in for 6 or 8 weeks, also multiple drains, as you can see here. And even with that, these patients often get wound breakdown, have to undergo dressings for periods of time before the thing finally heals. But this man could walk after this surgery. And so you really help these patients by removing these areas that are not going to otherwise go away. This is another kind of patient that I've seen. This is a completely non-compliant gentleman who was sent to me from a skilled nursing facility where they'd been trying to dress this wound and treat his lymphedema with therapy, which just wasn't working. And so they thought that he needed an amputation. But in fact, we did a Charles procedure on him, which is ugly, but worked much better for him than an amputation. Well, this patient who has lymphedema tarda, at the age of 30, she was normal. And at the age of 40, as you see here, she's got extreme lymphedema. And really the only thing we could offer her was excision, which we did over a period of a couple of years and 4 operations. And I took a total of 380 pounds off her, which is horrible. You can see I've harvested skin grafts here from the excised tissue to place over the fascia after the lymphedema has been removed. But nevertheless, we were able to return this patient to a relatively normal life, where she could drive her car, where she could pick up her kids from school, where she could look after herself, whereas previously she'd been bedbound. So this is horrible and destructive surgery, but for selected patients, it works, and I still do it from time to time. Now, getting back to how I got into this, I was aware of Bernie O'Brien, who's a Melbourne plastic surgeon who started doing lymphatic venous anastomosis in the 80s. And I actually did some in the 90s. I did a handful of cases, all lower limb cases, and I did medial thigh collectors. I'm sorry, let me just go back there. Medial thigh collectors, just because we knew where they were, end to side to from the lymphatic to the vein, which is quite often the saphenous vein, and it didn't really work. We might see some improvement for a short period of time, but ultimately it came back. Plus, it wasn't reimbursed by insurance companies, and several people who started trying to do them just abandoned them, and I was one of those. And it wasn't until 2005 that I got interested again. This is a group picture of the International Perforator Flap course that was held in Barcelona in 2005. This is a course that a bunch of us hold every year in different parts of the world. This is Asao Kashima. And during this course, we have live surgery sessions where we demonstrate some of the flaps that are talked about during the meeting. And this is Dr. Kashima doing a lymphatic venous bypass. And we all scrubbed in at various times during this procedure to see what he was doing. This is Jean and Asia. You can see the monitor at the back. You can see the LVB going on. And we looked at this, and none of us had seen anything like this before, but it certainly whetted our collective appetites. So the algorithm changed for me to including an LVB, though we still had no other investigation other than lymphoscintigraphy to go by. And the big problem was, where is the lymphatic? How can you find lymphatic? You certainly couldn't find it with lymphoscintigraphy. Now, I was aware that Kashima used indocyanine green, and we were using indocyanine green for lymphangiography, for angiography, but not lymphangiography. So off-label use, but I was able to get IRB approval, or the approval to use it under an IRB protocol that I got. And so then we started adding ICG to the algorithm. And I found that I was doing fewer lymphoscintigrams. So if I had a patient where the diagnosis was already established, I didn't necessarily do lymphoscintigram, but went straight to ICG. And if I found no lymphatic channels, then I couldn't do an LVB, so either conservative therapy or some form of excision. But if they had lymphatic channels, then I could offer patients a lymphatic venous bypass. Now, Hakan Borson enlightened the lymphology world in the early 2000s, and in fact, he was derided about it initially when he presented it, but he showed that in lymphedema, adipose tissue, fibroadipose tissue accumulates and could be treated with liposuction. And I didn't use liposuction initially because I was concerned about patient compliance. Because of our healthcare system, many patients can't afford compression garments, and their insurance companies won't necessarily cover it for them. And it's a real problem that continues, I'm afraid. But I was also concerned about the fact that liposuction was not treating the lymphedema. And subsequently, as you see, I started using it as an adjunct. But Borson showed us that you could reduce the bulk of an arm, for example, without significantly altering the impaired lymphatic transport. So that bothered me. Now, I was aware that people were doing vascularized lymph node transplant, and I didn't do it initially because I was concerned about donor site morbidity. There were several reports of lymphedema being induced in areas where lymph nodes had been harvested. And also, I was confused as to where the nodes should go. Some people were placing them in the area of lymphadenectomy, some people were placing them distally, and I didn't know which was right. So initially, it seemed to make more sense to me to place them at the site of lymphadenectomy. Again, as a sidebar, I discovered that when I started doing this, you have to very radically excise all of the scar tissue in the axilla. This is the axillary vein that's being basically skeletonized. And I started measuring the flow in the lymphatic vein with a Doppler probe before and after, before excision of the scar tissue and after excision of the scar tissue. And I found that I could double the flow on the axillary vein. So in certain patients, there is an element of a venous element to the lymphedema. And now I look for compression of the vessels in the when I'm having an MRI done by the patient. I'll talk about MRI in a minute. So with that knowledge, I subsequently started placing nodes more distally in certain cases, and I'll show you this case again in a minute. Sometimes I place them at both sites, and mostly I use supraclavicular nodes because there seemed to be less donor morbidity from that site than some of the other sites. But more recently, I changed to using gastroepiploic nodes based on the gastroepiploic artery, which is very fast and easy to harvest through a small 5-centimeter incision. And the beauty is that you can divide this flap into two. So you can place one part in, for example, the axilla, another part in the wrist or the elbow, or wherever you decide to place it. So back to our algorithm. We're still just using lymphedema. This is exactly the same as the one I just showed you. But we now started adding vascularized lymph node transplant actually to both of these patients, patients with no lymphatic channels and patients with lymphatic channels, depending on the circumstances of the particular case. So I want to talk to you also about my practice development. So initially, when I started treating lymphedema, this is after 2005, patients would be seen randomly. They'd come maybe with something else, but have lymphedema at the same time. I managed to talk to several of these patients and explain that I was starting to do this surgery and wasn't sure how well it would work. And most of these patients jumped at the chance to have anything done. So the first year that I started doing this, I did 5 patients because I wanted to be satisfied in my own mind that there was an effect from lymphatic venous bypass. And there was. And so I spoke with our oncologists and they started sending me their lymphedema patients. And so all of a sudden I started seeing more lymphedema patients. But then patients talked to each other, and through word of mouth and Facebook and stuff, my practice snowballed, and I started seeing patients with all sorts of conditions, some of which were lymphedema, some of which weren't. And I realized that we needed better diagnostic tools. Now, I was aware that patient assessment is extremely important, and we all do kind of the same thing. History, of course, physical examination, limb circumference or limb volume calculation. I started using bioimpedance spectroscopy and, of course, imaging. And what I found is that none of these modalities on their own are pathognomonic for the diagnosis of or the assessment of lymphedema, but taken together, they can give you very good information, and they allow you to follow your patient and get serial measurements so you can see the result of your treatment and see whether you're actually helping the patients or not. Now, I was aware that at the University of Arizona in Tucson, the doctors, Wheaty, had used magnetic resonance imaging to look at patients with lymphedema. And so I spoke to one of our own radiologists who was actually really interested in the concept of developing an LE&RN program for our lymphedema patients, Jeff Mackey. And we developed that over a number of years. And he actually came up with the dark blood MR lymphangiography, which you see here, using a dual agent combining gadolinium, which shows you the lymphatics, and an iron contrast agent, which allows you to block out the venous signal. And so you know what you're looking at are lymphatics and not veins. And that was extremely helpful. And the advantages of MR is that it gives you useful information on the anatomy of lymphatic channels with high definition images. It documents where the edema is maximal. It demonstrates areas of dermal backflow and documents lymphatic function with accurate limb volume measurement and really valuable information on the limb other than the lymphedema. And these images are consistent. And this is an example. This is a patient with Milroy's disease, and you can see he just has one lymphatic channel crossing the ankle mortise. So he's not really a candidate for an LVB. But look at the fatty accumulation that you see in the right leg compared with the normal left leg. And this is a really interesting paper that Joe Diane published just last year. showing two patients with ostensibly the same type of presentation, lymphedema on the left leg, lymphedema on the right leg. But the MR told a completely different story. So fat is white and fluid is black, essentially, in MRs. And look at this patient, a lot of fatty accumulation in the right leg here, as you can see, with not a lot of fluid, as opposed to this patient who has a large fluid element and very little fatty accumulation. So the MR gives you a lot of information about what's going on in the leg or in the part you're examining. And show you this patient again, I decided to put these lymph nodes in the wrist because the MR showed a lot of lymphatic leakage in the hand, and I couldn't see how putting these lymph nodes in the axilla would drain that hand. And so we put them in the wrist and did in fact drain the hand. So this patient was able to discard her glove and get her hand back, which is huge for these patients. This is another patient who presented with penoscrotal and left lower extremity lymphedema. And imaging showed that he actually had a multiloculated lymphangioma that you can see here that extended all the way up his core to the diaphragm. And what he presented with was that every 3 or 4 weeks he'd get very short of breath, and then he would notice lymph leakage from the scrotum and from the leg. And what was happening was that the lymphangioma was filling, and as it did so, it impeded the movement of the diaphragm, and then it decompressed itself by leaking lymphuria. And what we did for him was distal LVBs to decompress the lymphangioma and prevent the respiratory symptoms, which fortunately was successful. Here's another patient who presented with bilateral lower extremity lymphedema, but imaging showed that he had complete fatty degeneration of his musculature. So that was the primary problem. His lymphedema was not the primary problem. And this is another young patient, young man with lymphedema of the left lower leg. But imaging showed that actually his problem was a large lymphangioma that you can see right here. And so we were able to excise that and solve the problem for him. Here you see the lympangioma excised, and here it's closed. The price he paid was a big scar on his leg, but he no longer had that large swelling. So getting back to our algorithm, we're really back at the same picture again. For patients who've had previous nodal dissection, no nodal dissection, this is what you've seen before. Patients with lymphatic channels, often an LVB plus or minus lymph node transplant, or LVB alone. But adding liposuction, as I mentioned, or might, a year after the reconstructive procedure. And liposuction as an adjunct, I found to be very useful. I do it about a year post reconstructive procedure under tourniquet control, the way Dr. Borson has taught us. Put the patient in compression in the operating room, and I keep them in compression, 24/7 compression for 3 months after. And this is assuming that they've had a response from their lymphedema surgery, which I measure usually with all of the things I talked to you about, bioimpedance spectroscopy, limb volume circumference, all of these things. One of the keys is to use, this is a 4 millimeter basket cannula, and you need that to break up the fibrofatty tissue, which is otherwise very difficult. And you can see how aggressive I am with the suction down here. And I found that to work really well as an adjunct. The other thing we've added is prophylaxis, the lympho procedure that was first published by Dr. Picardo. And we've started calling it immediate lymphatic reconstruction for the reasons I've told you. Done at the time of lymphadenectomy. This is a breast cancer patient requiring an axillary dissection, injecting isosulfan blue. And here you can see several lymphatic channels that have been imbricated into this vein in the axilla on completion of the lymphadenectomy. And there have also been developments in imaging, and the newest one is really ultra-high frequency ultrasound imaging. Just see if I can move this thing. It doesn't want to move. But here you can see, this is the greater saphenous vein. There's a lymphatic channel over here. This is a saphenous nerve. And when you move the probe over the limb, you can see the vein collapsing, but the lymphatic doesn't collapse. And so it allows you to see veins and lymphatics. And this is a paper from Aki, whom you hear about during this meeting, or you hear from during this meeting, showing that even in an area of dermal backflow, you can identify a vein and a lymphatic, and you can actually do lymphatic bypass within the dermal backflow, which is something that we've kind of shied away from with using ICG alone, because with ICG, you just see this white blob, as you can see here. And so that has led to the current iteration of my algorithm using MRI, but possibly the addition of ultra-high frequency ultrasound, and addition rather than substitution, because I think all of these things are useful, and the more information you can get, the better. Goes down along the same path as before, as you've already seen, but with the addition of dermal backflow. And I have, up till now, started putting lymph node transplants in areas of dermal backflow, but with the advent of ultra-high frequency ultrasound, you can see it's also possible now to do LVV in those areas. So that's really what has changed with ultra-high frequency ultrasound, which I think is a great addition. Now, the other thing that you need to remember is that there's still a place for direct excision. The prophylactic surgery works in preventing the development of secondary lymphedema. It's a very useful addition to our armamentarium. And again, of course, the addition of the liposuction or minimally invasive tissue excision helps to complete the picture. Now, this is going to change again as further developments happen, but that's essentially how I got to this. And I look forward to answering questions during the Q&A session. Thank you very much.
Hey, Peter, how are you? Good morning.
Good morning.
I saw you on very early this morning with us.
Yes, I was. I got a text at 3:30 a.m. and I was sure that my talk wasn't until now, but I couldn't go back to sleep, so I just got up.
Well, we've got some persistent event organizers, so thank you very much for joining us. That was a lot of fun for me to watch how your algorithm has changed and molded over time as new technologies come through. So thank you. I just want you to know we're also inviting the next two speakers to join us if they want live for Q&A. So I think it's going to be Hakan, and if Takumi can get on as well, we'll have him. I just wanted to make one comment / question. I remember it was a few years ago, Babak invited our group to talk about, to write about lympha in one of the invited articles, and we decided to call it immediate lymphatic reconstruction because that's what we felt it was. And then we actually wrote in that article, and this speaks to how you recommend we call lymph node transplant, and lymphovenous bypass. I'm all for it. But what we also wrote in that article is we think we should be talking about those procedures collectively as delayed lymphatic reconstruction, because insurance companies are going to recognize immediate breast reconstruction, delayed lymphatic reconstruction, delayed breast reconstruction, and the parallels in lymphatic. So I would be a fan of saying, look, let's call it delayed lymphatic reconstruction, and then we clarify. And for this delayed lymphatic reconstruction, we're going to do transplant or bypass. What are your thoughts on that?
Yeah, I think that's very reasonable, because then you have immediate lymphatic reconstruction, which is the lympha procedure, and you have delayed, which is the other two. I think that makes it very clear to everybody what we're doing. And insurance companies they're very resistant to conceding that we're doing these things.
I hope you join us during the keynote address, because you're going to hear from. You're going to hear about what we did with one of the insurance companies here in Massachusetts, but I want to pass it off to my co-moderators and for any other questions.
Peter, it's great to see you, and I really enjoyed your talk.
Hi, Aaron.
I guess my question is, do you routinely obtain imaging post-operatively after your physiologic procedures to try and assess the efficacy of the procedure? And if so, how often do you see improved physiologic function?
I have found it difficult to get patients to consent to repeat MRI unless there's a very good reason to do it. So if it's just a case of me wanting to see their MRI, most of these patients don't consent to that because they find the MRI an uncomfortable procedure. However, I do a lot of imaging with ICG in the clinic postoperatively, and patients tolerate that very well. If patients are not improving, then obviously I go back to the beginning and start with lymphoscintigraphy, MRI, all of the other things again. But if they seem to be improving clinically, then I just follow them with clinical examination, the patient-reported outcomes and ICG.
Terrific. And one other question: when you combine an excisional procedure with a physiologic procedure, how do you stage them? Because some people are doing it at the same time. Some people would do the physiologic procedure before the excisional procedure, et cetera. But what are your thoughts about that?
It really depends. I mean, for example, that gentleman I showed you, the morbidly obese gentleman, he didn't need any physiologic procedure because he didn't really have significant lymphedema. He just had this localized huge festoon of lymphedema in his leg. But other patients, for example, frequently I'll find, breast patients, for example, post-mastectomy patients who have large upper arms. And sometimes in those patients, I will combine a brachioplasty with a axillary scar release and lymph node transfer at the same time. So it depends on the patient.
Thank you.
Dr. Borson, looks like you have a question. Do you want to come on mute?
It's just a comment. We are lucky in Sweden that we don't have any insurance companies chasing you, since we are all covered by any medical procedure or compression garment. So that is, I think, one thing that we have good results. That was just a comment.
And then maybe one final question just from the audience. Dr. Neligan, what product do you use for your 24/7 compression?
So what I do is, and again, it relates to what Akan just said about compression garments. At the end of the procedure, I wrap the limb in Webril and Coban bandaging. And I leave that in place for 48 hours. And then at 48 hours, I have them take that off and we put them in their compression garment. And usually I will get them to have new compression garments ready for their postoperative treatment. And so then they just go into regular compression garments at 48 hours. And I have them have two pairs, one in the wash and one on them. So they're in compression 24/7.
Great. Peter, thank you so much. And we invite you to obviously stay on throughout the meeting, but the next two sessions, you can pepper your colleagues with questions as well.
Thanks very much, folks.